Hello and welcome to today's Tiger webinar. I'm Bill Sackman from RIT's Division of Development and Alumni Relations, and I'm here to welcome you to this evening's webinar. We are happy to have you join us today and hope that you and our entire Tiger family are well. As we all continue to weather this new working environment, we want you to know that the RIT Office of Alumni Relations is available to help all RIT alumni with a variety of needs, including new virtual content, learning opportunities, and networking and career assistance through the new normal of pandemic realities. We especially encourage everyone to connect to the RIT Alumni Association social media channels, including Facebook, LinkedIn, and Twitter, where you will find up-to-date communications and opportunities to connect to other Tiger alumni in your region and your industry. Those links are found in the chat box. The chat box can be opened by clicking on the chat tab on the right of your webinar window. Many in our RIT family have asked how they can help students and the university as we respond to the pandemic, and we are incredibly grateful for those offers. There are two ways you can help. First, our new graduates and current students are seeking positions for full-time careers and co-ops. Many of these positions have been delayed or canceled entirely. If your company is hiring or would consider adding a co-op post, please contact Chris Steeler in RIT's Career Services Office and allow her to post that position in our systems. In addition, there is now an unprecedented need for financial aid scholarships for current and incoming Tiger students. If you are able, please make a gift at the link in the chat box. Thank you. We want to ensure that everyone is ready and familiar with the presentation tools. If you are joining from a remote location and are currently signed into your company's VPN, we encourage you to close that channel during the webinar to increase the quality of the transmission. The webinar platform is secure without VPN. All attendees have joined in mute mode. However, your questions can be entered in the chat box at any time throughout the discussion. We will make every effort to address all your comments and questions throughout the webinar. You are joining this event using broadcast audio. If you wish to dial in by phone, dial-in information is provided in the chat box. Live captioning is also being provided, and you can find the link to access that in the chat box as well. This webinar will be recorded and made available, complete with captions, in approximately 1 week following today's event. All participants will receive an email with the link to the recording. If you have any technical questions, please feel free to type those in the chat box as well, and we will do our best to get you the appropriate answers. Now, on to today's webinar, Medical Innovation in a Time of Crisis. The COVID pandemic has called for medical device companies to rapidly respond with needed medical technology. Companies are being asked to innovate in months and not in years, and production facilities are being asked to significantly increase production while also accounting for worker safety during the pandemic. To guide this discussion, we are pleased to welcome our moderator, Marcos Esterman, PhD, Associate Professor at Rochester Institute of Technology's Kate Gleason College of Engineering and the Department of Industrial and Systems Engineering, and presenters Joe McGuiggin, Principal Component Engineer and CE Team Lead at Zoll Medical's Resuscitation Division, and Joe Chiapperi, Head of Assay R&D at Ortho Clinical Diagnostics. Marcos Esterman, PhD, has over 25 years of combined experience in industrial and academic settings. Prior to joining the RIT faculty, he worked at General Electric Medical Systems and Hewlett-Packard. His analyst work at HP enhanced design and product architecture decision-making. Currently, he is an associate professor in the Industrial and Systems Engineering Department at RIT. His teaching interests are in product and process development and systems engineering. He also teaches in the multidisciplinary design and the Masters in Product Development programs. Marcos is the Director of Lean Engineering and Product Development Simulation Laboratory, which seeks to improve the effectiveness of product development and increase commercialization success by closing the gap between academic and industry. He researches structured product development methods and the integration of lean principles in the product development process. Joe McGuiggin is the Principal Component Engineer and CE Team Lead at Zoll Medical's Resuscitation Device Division for the last 10 years. A 2020 prospective graduate of the RIT Masters of Product Development program, Joe has been actively involved in the COVID-19 response effort through Zoll's ongoing Vents Saves Lives project since early March of this year. An electrical engineer by education, Joe has held positions test component engineering and program management at Raytheon Company, DEC, Solectron Technologies over the past 36 years. Joe currently resides in the Merrimack Valley with his wife and son. Joe Chiapperi has been with Ortho Clinical Diagnostics for over 28 years and is currently the head of SA R&D. Prior to this, he was the head of R&D at Transfusion Medicine. Joe has extensive experience in the new product development, program management, portfolio management, and strategic partnerships. Joe has led numerous programs across Ortho's business, including immunohematology, chemistry, immunoassay, lab automation, and commercial excellence. He is certified process excellence black belt and holds several patents. Joe is an alumnus of the University of Rochester, where he earned an MBA from the Simon School of Business and a Bachelor of Science in Optics. Thank you all for joining us this evening, and now I'll turn it over to Marcos to begin tonight's discussion.
Thank you, Bill. So first of all, welcome everybody, and thanks for attending this. A little bit of background on my interest in this topic. As Bill mentioned, I have a lot of experiences and interest in product development. Last year, I began a partnership with Sandra Rothenberg, where we started looking at how regulation and innovation have interplayed in medical device development. And that group has expanded to include Ezekiel Leo and Ettore Spadafore. So this is a topic we're very much interested in, and COVID represented an interesting opportunity to see how it was impacting the product development and innovation process. So the first person I'm going to introduce is Joe McGuiggin. I've had the pleasure of having Joe both in my classes, and I am his current capstone advisor. And I know that he's juggling a lot with both trying to finish up his capstone and respond on the topic that he's talking about. So at this point, Joe, I'd like to turn it, Joe M, I guess, since we have two Joe's, turn it over to you and have you give us a little bit of background.
Thank you, Marcos. Hello, I'm Joe McGuiggin. First, I'd like to thank Bill, Sandy, and Marcos for the invitation to join the series. I'm very happy to be a presenter and a panelist here tonight. I'm a last semester product development grad student, is how I'm calling myself, studying with Dr. Esterman and scheduled to complete this summer. My research interests are focused on knowledge management in product development organizations and impacts on process and outcomes. And I've been studying the impacts of visualization tools during concept development in that realm. At Zoll, I'm a full-time employee working with the component engineering and sustaining engineering teams. In that role, I'm responsible for component selection and processes related to those activities, AML, purchase specifications, creation and maintenance, and component obsolescence management. As a company veteran, I'm often consulted by other developers, and even more often now as we progress through the pandemic. I'm a frequent member of ad hoc cross-functional teams to help resolve issues where components are involved. Next slide, please. Zoll's products produced in Chelmsford are critical for care of pre-hospital and hospital patients with acute illnesses. So with COVID disease, we see that in the advanced stages, breathing becomes very difficult and often requires mechanical ventilation. Our ventilators have become essentially our single most important priority for me and a majority of the people in Chelmsford since the beginning of the state of emergency this March. The steep ramp caused by many unforeseen problems with our supply chain has been one of our biggest problems. This in turn was amplified, and I can get into some of the issues that we had there, but I don't want to go too much further. I'll turn this back over to Marcos at this point.
Great. Thank you, Joe M. Now I'd like to turn it over to Joe Chiapperi. The connection there for us In the past, I've taught systems engineering courses at Ortho Clinical Diagnostics, and we've been in conversations with them on and off about understanding some of the challenges that are faced by medical device developers developing complex products in a regulated environment. And when this webinar was proposed, I reached out, and Joe C. graciously agreed to talk about their experiences in responding to the crisis in developing the antibody test. So, Joe, I'll turn it over to you at this point.
Great, thank you, Marcos, and thank you for having me. You know, Ortho has a proud history in diagnostics. We're a global company. We serve hospitals all over the world. We also serve donation centers for people who donate blood. We do the testing. Our products are used for testing for infectious disease on donated blood. And we're also on the other side, in the blood bank side, where if you're a recipient of donated blood, we do a lot of the testing to ensure patient donor compatibility. So we have a rich history in working on infectious disease. And so COVID-19 was a natural for us, and we felt a need to respond. So I thought first I'd just give a little bit of background on the disease, because I don't know if everybody's familiar with SARS-CoV-2, COVID, and antibody testing. So COVID-19 is the disease. It's caused by a virus, a coronavirus. There's a lot of coronaviruses. The common cold is a form of a coronavirus. So the current one is SARS-CoV-2. There was a COVID-1. But if you remember back about 10 years ago, there was SARS, there was MERS. These are all similar coronaviruses. When you're infected with a coronavirus, typically within a small number of days to a week, you'll start to develop symptoms, and that corresponds to the onset of antigens and RNA in your system being able to be detected. So the initial tests are molecular, they're PCR tests. They can actually detect that you have the virus in your body. But shortly after that, the antigens start to disappear, the DNA starts to disappear, or RNA starts to disappear, and your body's immune response is what is detectable. So your body's responding to this virus invading its system, and it responds with different forms of antibodies. The first to respond is IgM antibodies, followed quickly by IgG. And in fact, the illustration, or the picture here, is really just meant to be illustrative. What we now know about SARS-CoV-2 is that IgG, IgM responded about the same time. So from the onset of symptoms, you have about 2, maybe 3 weeks to detect the actual presence of the virus itself. After that, it's probably undetectable, but antibodies will start to respond in about a week to a week and a half. So for long-term detection, you want to detect antibodies. And it's also, everybody's interested in immunity. So the presence of antibodies sustained over a long period of time generally correspond to immunity. Now, science still hasn't sorted that out yet with COVID-2, but generally this is how we determine that somebody has long-term sustainable immunity. The design of our assay, which is there's an architecture picture on the right, we basically coat a well with the antigen. In this case, it's the SARS-CoV-2 antigen, and then the antibody's presence in the sample will bind to it. We then have another conjugate also with the SARS-CoV-2 antigen that binds to the other side of the antibody. We hit that with a signal reagent, and we form a chemiluminescent response, and that's proportional to the amount of antibody present. So what worked out really well for Ortho was we do this all the time. We have infectious disease tests for HIV, for hepatitis A, hepatitis B, and HTLV, et cetera. So when we looked at this, we said we can leverage some of our existing knowledge and just replace the existing antigens, or let's say for HIV, with an antigen for COVID-2. So why don't we go to the next slide? So typically for us to do an infectious disease assay in a regulated environment is about a 3-year process. And it can be even longer depending on the clinical trials we have to go through. We did this one in 30 days, and so we took what was typically maybe a 36-month timeline and shrank it down. First thing, as soon as we decided we were going to engage with, we had to go identify available antigens. What helped us a little bit was China was probably about a month and a half ahead of the rest of the world in experiencing the disease. And antigen developers in China were already developing antigens, and we contacted many of them. We were able to leverage some of our existing assay design. We were able to develop a prototype assay in about a week. We developed a manufacturing site here in Rochester. Our normal manufacturing site is in Wales for large-scale manufacturing, but we took our R&D pilot facility and turned it into full-scale production, and that was that 1-week tech transfer period. Validation was about a week long. What also helped quite a bit was that the country, the United States, was responding because this was an emergency. And so the FDA eased their requirements, and we could go through what's called an emergency use authorization. So they waived many of the requirements of design control, and we just had to prove that the assay could work. So how do you turn months into days? I think you start with a strong capability and a history of infectious disease. That was a natural for us. Finding the right antigen was key, and we sampled, I think it was between 10 and 15. We got input from literature, we talked to key opinion leaders, we talked to the companies that were making it, and then we leveraged our existing design. So what helped us a lot here was the materials, so the raw materials that go into the manufacture of a test. We didn't have to find all of the new raw materials. The only one we had to find was the antigen. So we leveraged materials from our other tests and folded them into the design. And as I said, we used our existing coding line in Rochester. And then the hardest part actually during all of this was finding positive patient samples. So while the disease and the pandemic was growing, finding people that were actually positive for COVID and had COVID-2 virus in them, and then were developing an antibody response, getting their blood samples was quite a challenge because there was a lot of research going on. Everybody wanted it. So really, that's where we depended on our key opinion leaders and suppliers that we had long-term relationships with to help us there. And then finally, I think the thing that really helped us quite a bit too was I don't think you can ever underestimate the power of a highly motivated team. And I know it's just a phrase, but it's very true. People really felt like this is something that we consider core to what Ortho is about. And we said, if we're not responding, who is? With antibody tests. So people were willing to, we had people here in 80 hours weeks, working nights, working weekends to try and get there as quickly as we could. They felt really inspired. And I think you can't underestimate how important that is. So I will leave it at that, and maybe we can move on to questions.
Great. So I'll kick the process off, and Joe McGuiggin, I'll start with you. Could you give us a sense of the magnitude of change that was requested of you, with respect to not specific numbers necessarily, but what were we talking about, and what you were asked to do relative to what the status quo was?
Sure, I'd be happy to. So actually, the first slide was an announcement that Zoll made. I believe it was very early in March, that we were going to ramp up our production by a 25x scale. Now, anybody who works in a manufacturing environment will know what that means. It's an enormous jump from building a 1x to a 25x process. So the process of doing that just created quite a bit of havoc for us, to put it mildly. We had about a week to figure out how we were going to react to that. And we really didn't know what kind of problems we were going to hit. We had a pretty good idea that we were going to have a supply chain issue, and that we did. And we spent an enormous amount of resources trying to solve those problems as they arose. And you can imagine the meetings that went on a daily, sometimes twice daily basis, all hands on deck type situation, just to respond to shortages, for example, as we tried to meet those demands. And we did that, and now we're 3 months into that, and we're shipping ventilators by the tens of thousands, and we've pretty much eliminated most of the supply chain issues through an awful lot of hard work by a lot of people that as Joe C mentioned, people working 80-hour weeks was common, and a lot of resources spent, a lot of time, obviously a lot of money. Luckily Zoll is a very healthy company and can tolerate this type of a disruption. And those are the kind of issues that jump out at you immediately, I guess, in the forefront. some of the things that you don't think about were, how do you squeeze a 25x increase out of your factory? You can get all the materials possible, that you need, and how are you going to push that through your production line? And you can't. You have to expand. You have to create new production lines. So multi-purpose space became production. Office space became production space. We actually created a whole new production line in our facility in Deerfield, Wisconsin, from the ground up. There were, just enormous changes that happened, and just a very large number of people were involved that would have been working on other programs, on other products. So it was very disruptive in that respect. Let's see, what can I add to that?
Well, I can. So one quick public service announcement. So while I'm asking these questions, people, please feel free to post additional questions in the chat screen in the question screen, and I'll get those posed to our panelists. But kind of building in that.
Marcus, let me interrupt for a second. There was one other point that I wanted to make was so social distancing becomes a real issue in any factory now. So the risk of losing your workforce due to COVID infection is a very real, significant risk. If even one person tests positive, everybody in that vicinity also needs to quarantine. So you can very quickly lose a whole floor of your production facility. Mm-hmm. So those types of safeguards had to be put into place. So that required additional space because people had to be moved so that there was enough distance between benches, between operators and benches, and so forth. So these are some of the things that you would probably not think of until it became a real problem for you, if you were going through this for the first time.
Right.
Turn it back to you, Marcos.
Yeah, thanks. So Josie, you touched upon some of the factors that enabled you to go fast and really compress the timeline. Some of that was clearly superhuman effort, but were there other things that you learned from that experience that you think you can move forward under more normal operating conditions?
Yeah, I think so one of the things we did was we very early on reached out to the FDA and had a conversation with them and said, we're in development. We had some early preliminary data. We shared that early data. So this was before even a submission or any kind of formal. We reached out to them and said, this is what we're doing. And the conversation over the data, they were really pleased. And that developed some connections then. So both with the person who ended up being our reviewer for our EUA submission, but also other folks within the FDA. So as we had questions and we were, this was, and if you remember, this was very early on, right? So there's questions about, well, how many positive samples, how many negative samples, what's considered acceptable performance, and one of the challenges we faced was very early on. There was some of the lateral flow, small little tests, that could just have a red stripe for positive or negative, weren't very high quality, and that was suddenly becoming big in the media that the testing wasn't very good or very high quality, and we wanted to make sure, we had a top-notch test. So having a conversation with the FDA to say, what is it? What are you thinking? What are you looking for? To make sure when we did send in our EUA, it lined up with exactly what they were looking for. They didn't have templates at that point. It was very early. So I think one of the things I took away was, you're doing something new, just reach out and talk to your regulators as quickly as you can. And then that spreads across the world. We had to do the same thing throughout the world of different governing bodies in different countries about what is it they're looking for, because you're trying to find the right balance of following design control, but also trying to do this as fast as you can.
Okay, great. Thank you. I'm going to throw in a question from the audience here. One of the people is wondering what type of organizational changes were necessary to support this development, and I think both of you can tackle this question.
Sure, I can try. From what I understand, and I actually, I haven't talked to everybody in the organization, but I actually haven't seen organizational change as a result of this. We are pretty much, organized as we were. There haven't been any major shifts of personnel into, different divisions. Definitely some different responsibilities for different people. But organizationally, no, I don't think we changed our structure significantly.
Okay.
And I think on our side, to echo Joe, we didn't formally change an org chart where different people had new reporting structure. But what we did do was, as I mentioned, we had to scale up manufacturing quickly here in Rochester, and we took over one of the floors of our R&D building. So these are R&D labs and offices, and we started moving people around, similar to what Joe said as well. We also brought people over from another plant in Rochester to help with the scale up of manufacturing. And in a sense, you wouldn't have seen it on an org chart, but dotted line, they reported into me at that point to make sure we could get production scale up going. What we also did is we took a very hard look at our portfolio. So when we looked at everything that was in development, we went to the bottom half and said, we're going to slow that project down. We'll just delay that one to start moving people onto antibody development for COVID-2. So we did do some prioritization to say we're going to consciously not work on some projects, and and then then move those people over to a brand new project that just suddenly sprung up.
Right. Nice job, Joe. That you anticipated another question that was asked by someone in the audience was, what impact was there to the rest of the portfolio? And that makes sense. There would be some reprioritization. Joe M., I assume there was some of the same in your organization, that some projects had to take a pass.
Certainly, repurposed space. So, some lines, may have gone down for, short periods of time while that was going on. I haven't really heard that we are, cutting back on any deliveries. So I think, from that perspective, I don't think there was a lot of change. One thing I'd like to add, though, is that I know Joe C. mentioned, going to the regulators, and that kind of reminded me that it wasn't necessarily the regulators, but Zoll did receive quite a bit of attention from FEMA as this rolled out, and I believe there was a good deal of support provided by FEMA, working with different players and actors in the supply chain. And I'm not sure exactly how that all went down, because some of that's probably, still in investigation stage. But I believe there was some people that were doing some hoarding or whatever of some material that were addressed, and we got our parts. So I know those are the kind of things that will happen in emergency situations like this too. So probably not a surprise that happened here.
There's a couple of questions that center around the issue of supply chain, and one person is asking specifically around the sourcing of the personal protection equipment for your support. I assume that must have been a challenge for each of your organizations. How did you get around those issues, and particularly with any other critical raw materials? There's an acronym I'm not familiar with. Maybe you guys are. OUS, critical.
Outside US.
What's that?
Outside US?
Maybe maybe if the person wants to clarify what they mean by OUS, I'll get that to you. But I think you get the gist of the question. So a couple of people are really interested in how those issues were overcome. Yeah. Outside. OUS is outside of the United States.
Yeah. Personal protective equipment was a challenge. I think in the first days of this, we weren't wearing masks yet. And in fact, if you recall, we were probably discouraged from wearing masks because we wanted to make sure, health direct to patient healthcare providers had access to them. But then all of a sudden we should be wearing masks, and you couldn't find them. And I have to say, I had some people volunteering. They were sewing masks, and they would be bringing them in, 20, 30, 40 at a time. We eventually got into a supply chain where we could find masks. We have normal stuff like gloves, lab gowns, lab coats, because we work in a BL2 environment. But we don't typically deal with respiratory issues. So So more, it was finding the respiratory stuff. We had face shields made. And I think Joe mentioned it starts to get crowded in a manufacturing space, and you're worried about your workforce. So, I think what I found too is one of the challenges was both managing the project to get this done as quickly as possible and managing the health and welfare of our people at the same time, plus everything they were going through in their home life, right? Because so you're dealing with a really concerned workforce. You're trying to keep them as safe as possible. We put other protections in, like we did temperature checks on entering the building. We limited the access to the building. So the vast majority of Ortho Clinical Diagnostics is still working from home. And it was only the people working on COVID that came into the office. So we tried to protect people by separation. We limited, the number of people in conference rooms, and cut back on that. So where we could get or make our own protective equipment, we did. It's becoming more plentiful now, but we also did things to separate people.
Okay.
Yeah, from our perspective, I really don't have that much knowledge of how that was handled. I can say that I know that at one point we were having a very difficult time getting nitrile gloves. We don't necessarily need them for biological protection, but we use them for ESD protection on our production floor for the electronic equipment. And it turns out that they're probably coming from the same factories originally at some point, or at least the same materials. And there was a shortage. That was the only thing that I had heard as far as any kind of protective equipment.
Okay. So one of the here, oops, some questions here. So Joe M, I think this question's for you. Why are companies redesigning new ventilators as opposed to just manufacturing existing designs? Are these designs fundamentally different with respect to costs or ease of manufacturing? So understandably, right? I mean, since
I'd have a hard time answering that one either. I know there's an awful lot of work going on with ventilators. There seems to be a very heavy influence or impetus, to build them because of the shortage. So I think there's definitely a lot of incentive to build ventilators. And, if you could go back to that slide that shows our ventilator, that I think, I don't know if I can't see that slide right now, but I'm assuming that there it is. Okay. Maybe there, yes. So that's a transport ventilator, as it's known. There's different types of ventilators, right? There's this is a full function unit. It has a variety of different modes it can operate in. It's certified for use in an ambulance or in hospital. It can be configured to go into an MRI lab. There's a lot of different uses for this particular unit, and it's what I would call a full featured ventilator. And maybe some of the other units that people are trying to build right now are more single function versus multifunction. They may not be as configurable by software. They could be, hardware driven units. I don't really know. I'm not a ventilator product specialist. I'm not a clinical specialist either, so I don't want to tread too heavily in areas that I don't know a lot about.
Right.
But, I think there's probably a lot of money out there, for ventilation right now, and there's a lot of companies that are trying to, jump in maybe in profit.
I mean, I think the spirit of the question, right? It seems like since the need was capacity, taking designs that are already existing and getting partner companies to just focus on building manufacturing capacity instead of redesigning it. But maybe there's some issues relative to intellectual property protection and structuring those partnerships might have taken longer than just redesigning something from the ground up. I don't know, but
yeah, that's very true. I saw the 60-minute special about the I think it was Ford multi-purposing a factory.
Mhm.
And then they used an existing design, I believe, that they partnered with. So
Okay.
that one seemed to go pretty well.
So Josie, I'm going to direct this question to you. So there's a question related to the handling of the verification and validation aspects of the process. And I understand that some of it is probably abbreviated due to the emergency use authorization, but is that work ongoing and kind of what happens? And are there, concerns or is there a need to continue following up on that validation and verification data?
Yeah. So to get the initial emergency use authorization, we went through we wanted to make sure, one, the test is safe and that it's effective. So we cared about two things very strongly. One is specificity. So specificity is, if you're negative, we want to get a negative result, because the last thing we want to do is, if you don't have antibodies, is tell you do have antibodies, because that might induce risky behavior. So it was critical to have very, very, very high specificity. Sensitivity is also important as well. So that's the opposite. That says, I want to detect it if you do have it. So you're finding the balance between the two. We spent quite a bit of time on making sure we got that right. The other part then that's important is, because SARS-CoV-2 is part of the coronavirus family, and there's a lot of common coronaviruses. I think approximately 80 to 90% of adults have one or more. They've experienced one or more coronaviruses. We didn't want cross-reactivity. We wanted to make sure that we only detected the SARS-2 coronavirus and not other common coronaviruses. So we spent quite a bit of time on that, plus other common interference that we wanted to make sure our assay didn't react to that. So our focus was there. As an example, long-term stability. So normally before you launch a test, you put it on the shelf and you see how long it lasts on the shelf. And we like to go out with 6 to 12 months of stability claims. Well, we didn't have 6 to 12 months.
Sure.
We looked at all the ingredients going in and we said, well, based on our experience with these ingredients, we believe we'll get 6 months. We had that conversation with the FDA. They agreed. And we said, we're going to put it into real-time stability now. That test is still ongoing. So we have product in real-time stability. But then also what we said is, look, at some point, the emergency will end and the emergency use authorization will go away. And now we'll have to 510K the assay. So we're in the process of putting together all of the stuff that we didn't do to have a fully fleshed out design history file and all the materials we need for a 510K.
Got you. Great. Thank you. Let's see this question. So this question really relates to clinical studies. I'm not sure that either of your products, right? I would assume each of your products, you referenced the 510K process specifically, and Joe, I believe ventilators are also 510K. So neither one of these products would have clinical study requirements associated with them. Is that correct?
I don't know for sure that this is not a PMA product, so I would be careful with that.
Okay. In the case of our test, it depends on the claims we want to make. So initially, when we worked with FDA to establish claims, so what do we say the assay can do? And one of them initially was, can it be an aid in diagnosis, aiding in diagnosing you actually have COVID-19? And the FDA kind of frowned on that one, and that would have required a trial to prove that we could detect it. So we said, well, okay, we're going to claim we can detect antibodies to SARS-CoV-2 and leave the interpretation of that to the medical practitioner. So it's about what you claim. We are working on the ability to claim correlation to what's called neutralizing antibodies, which are the ones that provide immunity. So we can't directly say immunity because science hasn't determined that yet, but we can claim a strong correlation to the presence of neutralizing antibodies. So that's a claim we'll add to our assay once we finish that study.
Yeah, and Marcos, in that case, since our product's an existing product that we've been shipping for, well over years, that's a kind of a non-issue in this case. It's not like we didn't change our design to ship this unit.
Right. Sorry. So I guess one of the questions that was floating around my head when you were talking about, it seems like you're in an interesting scenario because you're building all of this excess capacity And are there any concerns about then all of this, the demand signal suddenly dropping, right? And what do you do with all of this excess capacity? Some of it sounds like it's flexible, but I'm kind of curious, was there any, I don't know if you even had time to consider or think about that. You just had to react and go.
It sounded to me like it was pretty much just go do it, because we have orders, with the U.S. government, and people were getting calls from Washington D.C. and they wanted to know when the ventilators were going to be there, kind of thing. There was a lot of pressure on our management to deliver, and I won't say they transferred that directly to us, but we definitely understood that there was a lot of pressure to deliver, and I think people responded to that. But at the same time, as Joe said earlier, there was a dedicated team, and people felt they wanted to make a difference and do the right thing, and that's why we were doing what we were doing.
Marcos, I think one of the challenges none of us know is how long this pandemic will last.
Right.
So when we talk about testing profiles and how long will we be testing people for antibodies to SARS-CoV-2, is it a few more months? Is it going to be years? And we don't know that. And there is this balance of trying to, how deep do you go on certain raw materials to make sure you can continue to produce it versus I don't want to stockpile a raw material that maybe I'll never use again, right? So it's a little bit, and I think this is just one of those things you learn as you go and you just keep working your way through it.
Right.
Yeah.
So again, I want to encourage people to keep throwing these questions up. So while I'm waiting for some of those to pop up, this lets me throw in another question in here. So one of the things that keeps coming up, right, is it almost seems like under these scenarios, right, the bureaucracy seems to go away. People they focus on what they need to do, and it on the one hand it sounds like superhuman effort, but on the other hand I think there's a certain efficiency that happens where there's like this unifying rallying cry that everyone gets aligned to. I'm kind of curious. I mean, how do you harness that part of it without the 80-hour work weeks, right? I mean, that part's not sustainable, but there's probably some sustainable part of everybody knowing how to work on the right things and all having that type of alignment. Do you think it's possible to continue some of that after all of this is over? Well,
I think a lot of it comes trickle down from management. I think the upper management team does a very good job of communicating with the workforce and letting us know that as we're making progress and that we're actually shipping units, and where customers are actually receiving units, and we're making that difference. I think some of that is maybe that's, you call it a rallying cry or whatever you will, right? But it's the reality of what your efforts are resulting in. So you can I think that's sustainable for sure. If that's the question, I think that's not something that's hard to sustain. But as you said before, you have excess capacity now, right? And what happens when you don't need to build 10,000 ventilators a month anymore? Assuming that's going to happen at some point. Maybe it won't happen until next year. It depends, how many of these units are going to have to go internationally, right? I mean, right now, we haven't even fulfilled probably our U.S. needs. I don't know. I mean, I'm not in sales, but I'm assuming that we haven't got there yet, and we'll be shipping, at the same time to other countries as well. There's just a very, very big market right there.
Marcos, I think one of the things I observed, I do think trying to maintain superhero levels of hours that people put in, that's not sustainable, right? But I do think what you quickly see is you quickly see the bureaucracy, and every company has it. We all have it. You see the bureaucracy and you start to question what value certain pieces add, because time becomes the most important currency. It's less about the dollars, it's about time. And I remember we had a conversation with our label provider. We had to get a box made with the name of the test on the box. And they said, yeah, we could turn it around in 2 weeks, which would have been great. And so we don't have 2 weeks. We need it tomorrow.
Right.
Time was the most important thing. If the box cost twice as much, we might have cared, when we're trying to control costs. But at this point, we didn't. Time was so important. Time was the new currency.
Right. Well, good. All right, a few more questions are trickling in here. That's interesting. So I apologize. Part of the questions is blurred out. I don't know why. What are some positive things that happened in the organization while adjusting to the pandemic? Well, I think this was in the same spirit that you would want to continue, and I think we've covered some of those strategies. Another question here has to do with and Joe M, this one's probably a little bit more directed towards you. The thoughts on how the open innovation effort impacted the product development. In particular, we've noticed that on the ventilator design, right, there's a lot of open source ventilator designs there. A lot of universities jumped into ventilator designs. There's the emergency use ventilator designs. I believe Medtronic opened up one of their products and made it available to the whole world to start from and develop. Did that impact you all in any way, or was there, again, not even time to even really see what was going on with those efforts?
Well, from my perspective, no, it wasn't an impact. I'm sure there's people at Zoll that were impacted. I mean, everybody has their own role, and I'm sure that maybe marketing would have had to react at some point. I don't know. That's a fact, but I mean, from my perspective, no, I wasn't impacted by any of that, other than the conversations that we had early on about the open source study that you were doing in your class.
Sure. Okay.
Pretty interesting.
Okay. Another question here is asking if there were any specific product development strategies that were employed that would help with the development effort or production ramp up. So I don't know if there's anything specific you can speak to there, but
I can comment there. I think I mentioned that we looked at the designs we had for several of our existing infectious disease tests, and so look, I'm an engineer by training, and we're used to modular design, but in the world of biochemistry, sometimes people don't think of that. But we looked at conjugates we had, we looked at reagents we had, and we said, can I just use the same reagent? Will it be effective on this test? Because I didn't want to have to formulate something new and source the raw materials. So there is some modular design going on here. We leverage pieces of other assay design to put into this assay. And I think that's one of the things that got us there so quickly.
Josie, I'm building off a question I'm seeing in the chat session here. Did you see, in your case, we talked about the ventilator product where a lot of players jumped in. Did you see anything similar on your side? Were any new players or unexpected players that maybe jumped into assay development, or is this pretty capital intensive and you need a lot of that background to even be able to play in this space?
So what we saw, there's sort of two classes of tests, if you will. There's tests that are run in large laboratories. For those of us in Rochester, at the University of Rochester Medical Center as an example, big, large laboratory. And it is capital intensive. You need large instruments. So the common players, Ortho's one of them, Roche, Siemens, Abbott, we all are in this space. We all entered. But what else happened was these more what I thought about lateral flow, or these more point of care type tests. All kinds of companies entered who weren't normally in the market. And that's both, it was good if they developed a good test, it was bad if they developed a bad test. And then that also caused problems in the press for the quality of antibody testing. So for the big players, we knew we had good tests, right? We're not alone. It's not an Ortho thing. All the big players had good tests, but we were fighting the perception of antibody testing isn't very good because of some of the smaller entrants who didn't have very good tests. So there was a challenge there. That was one of the learnings coming out of it was, we knew we could get there, and we knew we'd be fighting our typical competitors, but who else got there fast was some of these these little startups that just suddenly produced a lateral flow test, and then you look at the data, and the test wasn't very good.
Okay, great.
Yeah, one thing that comes to mind is I know this got some press too, but there was a lot of talk about putting multiple patients on ventilators, a single ventilator and have multiple patients teed off of it, sort of. And, I don't know whether that actually came to any fruition or not. I know there were efforts out there to, produce those valves and to try to, incorporate them into ventilator circuits. Not as far as I know that we did that, but I know that there were other companies that were, trying to get into that space that way. So there were innovations that were certainly tried. Again, it would be interesting to find out if any of that actually went through the EUA and is listed now. Last I saw, I was looking at the EUA for ventilators. I think it was a couple of weeks ago, and I hadn't seen any of that published as far as any of those devices listed yet.
Right. Okay. All right. Well, I think we're getting towards the end of our time. For me personally, I'd like to extend a thank you to both of you for your time and for sharing the efforts that you had. Bill, I think I'm going to turn it over to you, although I saw a question just.
Yeah, if you want to do that one last question there that popped up.
Let's see. Well, let's just read directly. Did government provide incentives to offset the financially inefficient ramp up or the increased development costs? Or did that have to be passed on to the consumer, or did you end up eating that cost?
From what I heard, we chose not to pass that on. So we ate it.
Yeah, I think on our side, so a couple things. There, BARDA, which is a part of Department of Health and Human Services, was issuing money to encourage development, and they continue to do so. In the case of our test, we priced it at standard cost for an infectious disease test. What was one of the challenges was getting reimbursement rates set. So if you think about this, you go in to have a test done, the lab conducting it gets reimbursed at a rate typically set by the U.S. government based on Medicare rates, and then we get a piece of that in terms of what we charge the lab to buy our test. So our pricing, we just priced at a typical price for an infectious disease test, and just ate the cost of additional production costs. So we had while we were scaling up production in Rochester, it was incredibly inefficient. We just lived with that. It was the cost of doing business.
Sure, understand.
Great,
Bill. I think I'm going to turn it back over to you.
Yes. I'd like to, Marcos, Josie, and Joanne, I just want to thank you all for your time tonight. If any of the viewers have any additional questions, you can email them to ritalum@rit.edu, and we'll direct the questions to the various presenters. All audience members will receive an email from us in about a week with a link to today's webinar recording. You can see a full listing of upcoming virtual events like today's webinar at rit.edu/alumni/tigers-staying-home for a listing of our upcoming virtual events, and it's right there in the toolbar on the right. We have several each week, and we'd like to include you in as many of these events as possible. Please exit this webinar by simply closing your browser window, and please do let us know what you thought of the webinar through a brief survey that will be sent to you via email. Thank you all, and have a wonderful rest of your week, and stay safe. Thank you, Marcos and Joes.
Thank you.
Thank you.
Take care.
Good night, everyone.